We can start, and I'll just request Dr. Ramesh to stop sharing the screen, then
Yeah.
I can come up.
Okay.
Yeah. I hope my slides are visible now, sir. I'm Colonel Pradeep Kumar, and
Yeah. I can't see your slides yet.
The slides are not visible, sir.
just a second, please. I also seem to be having some problems with starting. Are they visible now, sir?
Yeah. Go ahead.
Yeah. Good. Very good afternoon to everyone. I'm Colonel Pradeep. I am presently posted at Army Hospital, Ara. That was my previous resume. What I'm going to talk about today is that why we should be examining young patients' fundus more thoroughly and what is special about these patients. Mostly they are in a hurry. They don't want to wait in our OPDs. They generally have excuses why not to dilate their eyes. They'll tell us that they are unaccompanied. They have to drive back home. They promise second visits, never come back. And the biggest problem is that they have a belief of infallibility. Still, most of these suffer from preventable visual loss, and it is our responsibility to look at their fundus more keenly. And what I am here to talk about today are a few examples where diagnoses were missed because the fundus was not evaluated, the correct methodology to ensure that a retinal diagnosis is always achieved, easy ways of examining the fundus, and few take home messages. So, my target audience today are my non retinologist colleagues, my postgraduate trainees. The content may seem basic, but it is essential for a complete evaluation. So first coming to the tale of few specs in vitreous. Now, most of us, when we start examining the eye, and especially on the slit lamp, the moment we start with 90D, we try to focus on the retina. We forget that there is a huge space between the lens and the retina where the vitreous is lying, which is an important indicator of a person's health. So this 35-year-old male presented with floater with a best corrected visual acuity of 6.6 in both the eyes. And this is all that could be seen. If you see carefully, there are few yellow specks which are anterior to the retina. Out here, you can see them, and they were seen more keenly on a FA. Now, this patient, initial workup for uveitis showed a small nodules in the left upper lobe. They were the follow-up of 6 months. These specs, we tried treating them with systemic steroids. They'll reduce in size whenever the steroids are stopped. They'll increase in size. And that is when we re-evaluated this patient and came with this report on PET-CT scan. The PET-CT told us that this was probably a case of CA. The CT-guided biopsy told us that it was a non-small cell lung carcinoma. And surprisingly, the vitrectomy sample also gave the same report. The resection has been done, the patient is healthy, but simply because that we were able to look at this vitreous early on. So my advice that all of us, when we are examining our patient, should also learn to examine the vitreous before we focus on the retina. Now, the second case was of a 23-year-old lady where she was just not happy with the spectacles that she was getting, multiple change of spectacles. She had a best corrected visual acuity of 6.9 in the right eye, and everybody kept changing her spectacles. And this is what she had. So these young patients, they generally have inflammatory diseases. A very clear-cut diagnosis turned out to be toxoplasma positive, responded to intravitreal clindamycin and ozurdex, and has a stable vision. The tales don't stop here. So we had a fluctuating vision in a 31-year-old entrepreneur, 3 week history of episode of blurred vision, and everybody told that how much time are you working on your computer? He said 10 to 12 hours, and people kept treating him for computer vision syndrome, tear substitutes, and this was an easy clinching diagnosis had anyone looked at the fundus. Now, interestingly, when we started managing him and we referred him to our psychologist, we realized that this patient also had anxiety episodes, depression, and even suicidal ideation. He has received psychiatric help. We don't know whether we prevented a suicide or not, but it is important for us to help out these patients by looking at them holistically. Now, this was a 22-year-old lady, an aspiring pilot, but when she went for the medical examination, she was rejected, saying that she is colorblind. She is color perception 3 on our Ishihara chart. And she presented for reevaluation, saying that what is to be done. She was told that nothing more is required. But remember, this was a lady, and she had a color perception defect. When we looked closer, we realized that this person was suffering from a cone dystrophy. And there was a definite role of giving genetic counseling because she had a great reproductive career ahead of her. She had to choose when to have children, whom to have children with. The role of ultraviolet protection was there, which could have prevented worsening of this disease. And more importantly, we had to inform the patient that this was a progressive disease and not just a stationary color blindness. So this is important to look at these patients also. There was a 27-year-old national level marathoner. He completed his marathon and said there is heaviness in the right eye. And as it happens, he was told that it is because of excessive sunlight exposure. And he carried on for about a couple of weeks before he presented to us in this particular manner. Now, there was a case of a CRVO in young, which has a huge battery of investigations which needs to be completed before the patient can be disposed of. And after all the investigations, we decided that dehydration was the probable cause. He was advised that next time when he is doing his marathons, he should be more careful about his hydration. Though we treated the patient conservatively, we did not do any intervention. But one should remember this was too dramatic a disease to miss, and it's a potential lawsuit for the primary ophthalmologist. So even if, as has been said earlier, the vision is 6.6 or 6.9, please don't forget to look at the fundus. Now, there was a photophobic driver. He had developed photophobia in right eye, was being managed as anterior uveitis with topical steroids, and surprisingly cycloplegics. His pupil was dilated to about 5 to 6 mm, but nobody looked at the fundus. And after about 3 to 4 months of treatment, he comes to us. This boy has got classical disc involvement. There is an evidence of retinal vasculitis. And this is an obliterative kind of vasculitis. And on focus history, he gave history of urethritis, was diagnosed as a case of Behçet. Usually these young people on their first interview do not talk about urethritis. And he was evaluated and also found to have an associated subclavian vein thrombosis. So the importance of systemic diagnosis being clinched by looking at the fundus alone comes here. And there was a swimmer, 16-year-old lady. Again, she had a healed uveitis, best-corrected visual acuity of 660. This patient had developed an inflammatory CNVM. Everybody kept treating her for uveitis. Nobody looked at her posterior pole for almost 6 months. By the time we started the treatment, treated her, the final visual acuity which was recovered was 3/60. Perhaps had we intervened earlier, we could have saved much more vision. And lastly, we had a 36-year-old lady. The case of headache was already diagnosed as a case of amblyopia a few years back. And now in times of COVID, when she talks about anosmia, nobody wanted to see her. She came to our COVID facility, and this is what we saw. This is something that we had read in books, so I thought it would be very interesting to present here. This was a case of Foster Kennedy syndrome in which we saw anosmia. Anosmia, I had already read. This is the first time I saw it in a case of Foster Kennedy. And she had a classical olfactory groove meningioma. She has been operated. Her vision, at least in the left eye and the field, has been salvaged. So even in COVID times, it's important to look at the fundus, though one may not use the direct ophthalmoscope, but slit lamp biomicroscopy and indirect, there are very effective and safe ways of examining these patients. So what can we do to reduce these cafes, as we call it? First and foremost, as has been said by other speakers also, there are 4 components of vision. Acuity is just one part. Contrast, color, and field are important. And if we don't want to miss retinal diagnosis, we have to learn to assess them also. And color vision should be incorporated as a matter of practice. Next is swinging flashlight test. That we were talking about the assessment of CRAO. In a case of CRAO, very early in the disease, you can pick up a RAPD. So if you have a RAPD, one should start thinking in terms of more sinister diagnosis. And also, while you test the patient with a swinging flashlight test, it helps by inducing photostress. And if in the affected eye, the recovery of vision is slower compared to the other eye, one should start thinking in terms of macular dysfunction. And then one has to learn to practice non-mediatic fundoscopy. And it is not only the 90D lens, there are other lenses much more comfortable than that, which are available now. And one has to use the slit lamp to its fullest extent by using the red-free and polarized light while looking through the small pupil. And the ultimate panacea is dilate both eyes and have a look at fundus if your patient allows so. So there was a small study which we carried out, presented at APVRS, and just to cut short in the time, this is what we were doing. We allowed patients to examine in conventional way with 90 diopter and 20 diopter lens, and then switch over to the newer generation of digital lenses, pan-retinal lenses, and wide field lenses. And in the other half, we were doing the opposite. What we realized as results were that whenever the patient was using, or examiners were using conventional methods of ophthalmoscopy, they were missing fundus details, which were more easily picked up by using the new generation lenses. And why was it happening? I'll just show the images. On the left-hand side, you see a 90 diopter lens being used, 16x zoom. The moment you switch to 40x zoom, this is the kind of image it appears. It's not very clear. But when you use it with a digital lens, you see the difference. This is the difference between 90D and the digital lenses which are now available. There is some difference in their optics. And if this facility is available, most of us are in a position to use these kind of lenses. So how to diagnose? Make a complete assessment of vision. Don't stop at acuity alone. Use contrast, color, and field. Tell your optometrist to check them. Always look at the pupil. The glow of the fundus is again an important predictor. This is for all my non-retinologist colleagues. The glow of the fundus should always be looked for. And if there is anything abnormal, please dilate your patient and go beyond the standard 90D lens. This is something that I wanted to tell, that everybody should be conversant with looking for a RAPD. This is just I wanted to show for my PG colleagues, and try using this framework. That whenever you have to decide how I want to treat this patient, that are you equipped to treat? If you don't have access to an OCT, don't try to treat a DME standalone facility. If you don't have laser facilities, don't try to treat a PDR case. Try to refer them off. And you must address non-ophthalmological issues. When you have vascular occlusions, please involve a physician because they may be life-threatening. If you have CSCR, try a psychological counselor, and there are many more examples. And always have both short-term and long-term goals. For example, if you're treating a CNVM, anti-VEGF is not the only place where you should stop. Talk about engineering modification in the patient's house, low visual aids, so that you can have a long-term goal also. And don't try to treat something like this. This is one example where the primary ophthalmologist has tried to hold on to the patient for about 20-25 days before the patient came to us. And to refer these patients, you can do that to validate the diagnosis, bring the patient back to your practice, and you are welcome to treat them. For therapeutic purpose, for example, if you have a submacular bleed, yes, you will need a retina specialist. For a non-resolving vitreous hemorrhage, the indications are given in book. But more importantly, don't forget the legal aspects of referral. In a case of ROP or post-surgical complication, please refer these patients. So in a case like this, definitely it will be wiser to refer. And lastly, a few humble suggestions from my side, as has been reiterated: high index of suspicion, try a dilated eye evaluation in most of the cases, augment your diagnostic array with newer biomicroscopy lenses, and experiment with various slit lamp illuminations. Thank you so much. This is my email for contact.